Hello, this is Milton Greenberg. Today I'm presenting on the new coronavirus vaccine developed by Pfizer. This is the first vaccine that's FDA approved to hopefully stop the coronavirus COVID-19 pandemic. So this results were just first published last week in the New England Journal of Medicine, the safety and efficacy of the Pfizer COVID-19 vaccine, which was demonstrated to be 95% effective. This is really great. Let's dig into the data and understand a little more about the vaccine. So the vaccine works by inducing immunogenicity. It stimulates the immune system to develop neutralizing antibodies that can stop the virus in its tracks. So the way the study was designed is there were two equal groups of about 20,000 patients each. One group received 2 doses of the vaccine, shown here with this development name, and then the other group received placebo, so no vaccine, just shots of water or whatever formulation chemicals were used. So the vaccine elicited SARS-CoV-2 neutralizing antibody titers, and this is demonstrated in this group right here in this figure. So in placebo, the patients that did not receive any vaccine, there were no neutralizing antibodies. And you can see here after a single shot at day 1 and a follow-up shot at day 21. By 28 days, patients had developed a robust immune response that was effective in neutralizing the coronavirus. And this, importantly, is shown to be equal or maybe even a little greater than what you see in normal human convalescent sera. So this is sera taken from patients that have been infected with the coronavirus, have fought it off and recovered and developed their own natural antibodies against the coronavirus. You can see that the vaccine is inducing a similar antibody response at that same level. Importantly, this is observed in patients greater than 65 years of age, because obviously this is the group that's most at risk of developing severe COVID-19 disease. So the immunogenicity decreased with the age of the recipient. So people my age were able to develop much more robust responses. However, the elderly patients, 65 and above, were still able to mount robust immune responses that exceeded those of the convalescent serum panel, which is important because people were nervous about this going in, is that would elderly patients that have a little weaker immune systems still be able to mount these types of effective immune responses. So antibody responses in both younger and older adults showed a clear benefit of a second dose. So this is effective at building antibodies to fight the virus, but how does this translate into efficacy? So the Pfizer vaccine protects against severe disease. So in the placebo group shown here, this is the amount of people that develop symptomatic coronavirus disease. You can see that after the first day, about one patient per day is developing coronavirus disease just through acquiring it in the community. These are patients on placebo. But you can see here after 21, 28 days, once the virus is kicked or the vaccine is kicked in and the antibodies are being generated, patients that had received the vaccine are not developing symptoms like what you see in the placebo group. There's this big split between those two curves. And as far as patients that have developed symptomatic disease, in placebo group, in about 20,000 people, you have over 160 people that develop symptomatic disease compared to 8 on the vaccine. And then of the 10 patients that developed severe coronavirus disease, 9 of these were in the placebo group and just 1 was in the vaccine group, demonstrating a 95% effectiveness at preventing severe coronavirus disease. So in order to understand vaccine development, what we see here is that vaccine development uses a lot of older and slower research and development techniques. So you see here, chicken eggs are used for influenza vaccinations. Horseshoe crabs are bled because of the unique components of their blood plasma that can then be used for vaccine development and testing. But this Pfizer vaccine was used and developed with a brand new technology called mRNA technology. So this synthetic messenger RNA is a brand new innovation that is first utilized today in this new coronavirus vaccine. So synthetic messenger RNA is a new therapeutic variation on a naturally occurring molecule, RNA, that typically directs protein production throughout the entire human body. And so the way this vaccine works is this lipid nanoparticle that contains this RNA. It's administered to cells, and then these cells can then be used to develop these spike proteins. These spike proteins are now going to elicit immune response, and these antibodies are going to be produced so that when you encounter coronavirus in the natural environment, doing your day-to-day work, is that these antibodies will be ready to go to help protect you from infection. So there are about a dozen different experimental vaccines in late-stage clinical trials globally, but the ones being tested by Pfizer and Moderna are the only two that rely on messenger RNA. The Pfizer vaccine is the first RNA-approved or mRNA-based drug or vaccine to be approved by the US Food and Drug Administration, the FDA. So a novel virus meets a novel therapeutic technology. So you have all these odd clinical and pathological changes caused by this novel coronavirus, and you're joining it with this novel vaccine strategy of which we have no previous experience. So in order to be confident about this technology, first we need to understand it. So common adverse events associated with vaccination, you can have severe local site reactions, you can have fever, and some people and some vaccines, it can be so severe, it might lead to potential seizures. You can have hypersensitivity, so these are unwanted immune reactions that can be so severe they might result in anaphylaxis. So what is the safety profile of this vaccine? And in order to understand the safety profile, we have to understand the technology. Where did the technology come from? So this technology originated from a concept back in 1990, developed by UC Irvine's own Dr. Phil Felgner in the School of Medicine. But this was back when he was at the University of Wisconsin. Direct gene transfer into mouse muscle in vivo. They were able to inject RNA, and in this figure right here, just to represent a figure in black, this is a skeletal muscle, and this skeletal muscle is now expressing this foreign protein that was delivered through this RNA technology. In 2005, Dr. Carrico demonstrated that RNAs can be modified to modulate the immune response. So here in this figure is that Dr. Carrico took this RNA-based technology, brought it on immune cells, and demonstrated this robust activation. These little dots here in this upper right quadrant, these are activated immune cells. But what she did is she could modify that RNA through various modifications and not get that really robust immune reaction. You could modulate that immune activation by tweaking this RNA technology that was originally developed in 1990. So to commercialize this technology, two companies were founded. BioNTech was based in Germany, and Moderna was founded in Boston in 2010. So back in 2014, Dr. Carrico had left her academic position and had joined BioNTech. And in 2014, they published this blueprint on how to develop these RNA-based therapeutics that would then be the foundation and the scaffold that was used to develop today's coronavirus vaccine. So you have this platform technology where there's this linearized plasmid template that can be rapidly modified and brought in into a process called transcription, where then it can produce a molecule called mRNA that can be taken up by cells and used to produce exogenous proteins to elicit that immune response. So the RNA technologies can be rapidly modified to generate mRNAs appropriate for different diseases shown here. In addition, these RNAs can be further modified to boost their pharmacokinetic properties. What that means is that normally RNA, you inject it and it's rapidly cleared by the body. But you can modify that RNA using various technologies developed by these companies in order to keep that RNA around in the body longer to develop more strong immune responses. So this is a timeline of how this technology was used. So back in December 30th, 2019, almost a year ago, the International Society for Infectious Diseases reports an unexplained pneumonia in China. In January 2010, Chinese scientists published the genetic sequence. And the scientists at these companies were able to take that sequence without ever having touched the virus themselves, just the digital sequence, and they're able to plug that into their technology platform. And in late February, the first RNA-based vaccine candidates were delivered to the National Institute of Allergy and Infectious Diseases in Bethesda, Maryland. This is Dr. Fauci's institute. And now on December 11th, just 2 days ago, the FDA emergency use authorization of the Pfizer BioNTech COVID-19 vaccine. So a new technology that enables this rapid turnaround and rapid development that is unprecedented in human infectious disease. So there are painstaking efforts in this abbreviated timeline to de-risk the safety profile of the vaccine. First, the goal was to pick the appropriate dose. So in a smaller study, there are 3 different doses. And you see here that in the percentage of participants, about half the participants demonstrated some fever, headache, muscle pain, with 1 patient developing severe headache and severe muscle pain at the high 100 microgram dose. Because of this, the top dose was abandoned and that 30 micrograms was advanced into the later stage testing, and that 30 micrograms is what was approved. In addition, you need to pick the proper vaccine candidate. So initially, 2 different vaccines were tested in parallel, one being this BNT-B2, and this was associated with a lower incidence and lower severity of systemic reactions than the first generation, the B1, particularly in older adults. The difference between the 2 is what was the components of that RNA. The B1 vaccine encoded the receptor binding domain, and the B2 vaccine encodes the full-length spike protein on the coronavirus. And this B2 is associated with good immunogenicity, but lower adverse events, particularly at the 30 microgram dose. So this is what was advanced in human testing. So the adverse event data, the safety profile was characterized by short-term, mild to moderate pain at the injection site, fatigue, and headache. Adverse events were less common and milder in older adults compared to younger adults, surprising but good news. Systemic events were more common and severe after the second dose than the first dose, and severe fatigue was observed in about 4% of patients. So this is the most common severe adverse event. And this is observed at higher levels than is what commonly used in older vaccination for the geriatric populations, including your kind of standard flu vaccinations. So the incidence of severe adverse events was similar in the vaccine and the placebo groups. So you got severe adverse events in 0.6% of patients that received the vaccine and 0.5% of patients that received the placebo. And so these, are not necessarily due to the vaccine itself. So I've shown a little snapshot here. So you see after the second dose in the elderly patients, you get pain at the injection site in about 66% of patients. This is compared to 8% with the placebo, as well as some redness and swelling. In addition, there's fever in the elderly population, mild fever in about 11%, fatigue in 51% of patients. And again, this was 4% of patients in this age group after the second dose developed severe fatigue that eventually went away. And then headache, chills, vomiting, diarrhea, muscle pain, and joint pain. all the common adverse events, but these are expected when you're eliciting immune response. And importantly, these adverse events are less severe than the hospitalization that is associated with severe COVID-19 disease for the geriatric population. So importantly, the summary is that COVID-19 can be prevented by immunization. RNA-based vaccines are a new technology, new approach against infectious diseases. Remaining questions. This study was designed to identify adverse events that may occur in 0.01% of the vaccine recipients, but it was not large enough to detect less common adverse events reliably. So more data collection will occur as the vaccine is rolled out. Safety and efficacy was not done in children, pregnant women, or immunocompromised persons, so we don't know what this vaccine will do to that population. Whether the vaccine protects against asymptomatic infection and transmission to unvaccinated persons is still unknown, and how to deal with patients that did get the first dose but not that second dose is also an unknown. And we don't know yet the safety and efficacy of the Moderna vaccine. That's probably going to be coming out next week or by the end of the month. And then the safety and efficacy of vaccines developed using more traditional vaccination methods is still unknown. So all in all, good news. This suggests that this technology is safe and effective and hopefully will be the beginning to the end of this pandemic to hopefully stop further loss of human life, particularly in our geriatric population. Thank you for listening.